Hi, it's Kristen here at UT Southwestern Medical Center. Thank you so much for joining us for this week's chat on melanoma treatment options. I'm excited to be joined by Dr. Jade Homsi, who is the co-leader of the Melanoma Disease-Oriented Treatment Team here at UT Southwestern's Harold C. Simmons Comprehensive Cancer Center. Dr. Homsi specializes in treating patients with melanoma, advanced skin cancer, soft tissue, and bone sarcomas. So we're certainly excited to have him. I want to thank you, Dr. Homsi, for joining us.
Thank you for having me.
You know, I think this is something that I certainly see in the news more often with melanoma. You know, if you could, maybe we'll start with something that, you know, I think a lot of people hear, that why is it becoming more prevalent?
So I think before we get there, I think it's probably reasonable to give you just a little background on melanoma.
Certainly.
So melanoma is a type of skin cancer. Skin cancer is the most common cancer. Melanoma, however, is approximately 1 to 2% of all skin cancers. However, it's the most aggressive one, or one of the most aggressive ones. You know, the incidence or the number of new cases of melanoma have been going up pretty much for the past 20 or 30 years. You know, we approximately estimate that maybe 90,000 to 100,000 people in the U.S. will be diagnosed with melanoma this year. Melanoma, as I said, is a type of skin cancer, but it tends to be the more aggressive type. We don't really have a good idea or good explanation to why the number of cases have gone up and continue to go up at the time when other cases of cancer are going down. But we think that there's some risk factor for melanoma going up, such as, you know, the use of tanning bed, environmental type of, you know, changes in the UV lights. Some other factors that are also associated, family predisposition to melanoma and other factors. So that's just a brief overview of what's going on in melanoma.
Okay. Are there certain populations that are more susceptible to developing melanoma?
Definitely. So these are what we call risk factors. So patients or people who have fair skin, who have more what we call nevus or moles, are more susceptible to having melanoma. Patient with family members with melanoma. Patient who have other types of skin cancer as well are at higher risk of having melanoma. Patient who have a more sun exposure or a history of a sunburn, a severe sunburn in childhood, are also at higher risk of having melanoma.
Interesting. Okay, that's good to know. I know we have some questions coming in. I forgot to mention at the beginning, don't forget that we will take as many questions as we can get to, but our conversation with Dr. Homsi should not replace an actual doctor's visit, so we need to be careful about really specific questions. But I know we have one that came in here, and that is, you know, there's been some talk lately about toxic chemicals and sunscreens, and that could lead to increased, you know, melanoma and skin cancer. Is that a valid concern?
So these are all things that I think worth investigating further. We find out, you know, every day, and that there are some factors that could be contributing to developing skin cancer in general and melanoma in specifics. There's still not a good connections between all these issues and factors in melanoma. And I think what we need is more studies and research to look really specifically into every one of these toxins and other factors.
Good question. All right, we have a different question here from Veronica. Thank you for joining us. And it's specifically about melanoma. How early can you detect it?
So that's a very good question. Early detection of melanoma is a key. Patients who have their melanoma caught early, they have a very high likelihood of a cure from melanoma. So early detection is a key. The best way for early detection is by doing it yourself, so it's self-skin exam, and also by seeing a dermatologist on a regular basis. We recommend even doing a more aggressive monitoring and follow-up, especially if you have a family member with melanoma or you have a history of skin cancer, then I would recommend to have that in a more aggressive fashion, the follow-up and the monitoring.
Okay, great question. Thanks for joining us. We're starting to get some questions about treatment. And so before we get there, though, I want to ask you, how does medical treatment for melanoma differ from treatments for other cancers?
So that's a good question, and I think that's really what's happening in melanoma is the treatment for melanoma has really improved significantly in the past few years, and mostly due to exploring different treatment options. So what we usually use for a lot of other cancer, which is known as chemotherapy, for example, is rarely used now in melanoma. Most melanoma treatment is now based on something called immunotherapy. So this is the treatment that stimulates the immune system to kill the melanoma cells in the body, or based on a protein that sometimes is present in melanoma and it usually can be defective or abnormal. And the treatment is usually to target that protein. So these are the two main categories, the way we treat more advanced type of melanomas.
Okay. So what is the goal of melanoma treatment?
So definitely we always are looking for a cure. So patient with early melanoma, early stage melanoma, even melanoma that sometimes goes to the lymph nodes. The goal is definitely a cure. Most of the time that cure is achieved by surgery. Following surgery, we sometimes offer patient additional treatment to reduce the chances of the melanoma coming back. In patient with more advanced stage of melanoma, so these are what we call them stage 4 or patient with metastatic melanoma, the goal is to hopefully extend and improve the patient survival and life expectancy. And we've been very successful in the past 5 to 10 years as the life expectancy of patient with stage 4 has almost tripled in that period of time due to the newer treatment that we've been using.
Wow. That's pretty impressive to nearly triple it. So we've got some questions. We've got one here from Wayne, and we've got one here from Christy. Since Christy deals with something you just mentioned, I'm going to start with that one. And her question is that, it's pretty scary to think about the scars from treatment when you have surgery. Is it typical to have severe scarring when you have to remove a skin cancer or melanoma?
So that's also a tricky question. Depends on the size of the melanoma, the location of the melanoma. It's not kind of like one thing that we follow for every patient. So the biopsy. So this is how things kind of go. You go see your dermatologist or primary care physician. They find a suspicious mole. They do a biopsy. So that biopsy doesn't usually leave you with a big scar. Now, if the biopsy comes back as melanoma, then that's really when you're probably going to end up with a bigger scar. However, in most cases, we work with plastic surgeons in plastic surgery to help minimize the scarring and minimize, the way the scar looks in the future. So there are way around it, but sometimes there could be a scar and there could be some changes in especially when we remove the lymph nodes. There could be some swelling, or what we call it lymphedema, and that's something we manage, after surgery, and we have some good options for the patients to manage that.
Okay, all right. Well, thanks for asking the question. Here's the question from Wayne, and this deals with stage 4 metastatic melanoma. He says there are lots of ever-changing statistics on life expectancy with that condition. What's the latest life expectancy for stage 4 given today's treatments?
So most of the data now, especially the data coming from the immunotherapy used in patients with stage 4 metastatic melanoma, the most recent numbers, or let me take you back to what we say 10 or 15 years ago. For those who like numbers, patient with metastatic melanoma, or 10 to 15% of patients with metastatic melanoma were alive at 3 years. The numbers we're looking at now is anywhere between 55 to 58% of patients with metastatic melanoma alive at 3 years. So that's, as I said, it has almost tripled or more, and that's a significant change. And these numbers are changing every year because we have more and more follow-up. We're looking at patients now 10 years out and seeing the likelihood of these patients being alive 10 years and beyond.
Wow. So we've got a bunch more questions coming in. These are great. We're going to take as many as we can get to. This is an interesting point. When does an oncologist see a melanoma patient, and when does a dermatologist see the same patient?
Very good question. So let me try to answer that very quickly. So there is a condition that is called melanoma in situ. So that's what we call pre-melanoma. So you could have a biopsy that shows something melanoma in situ, pre-melanoma, that can managed by a dermatologist. Stage 1, so melanoma goes in 4 stages, 1, 2, 3, and 4. Most stage 1 are also managed by the dermatologist. Most early stage 2 melanoma are also managed by a dermatologist. When it gets to the aggressive stage 2, 3, and 4, that's the time to see an oncologist. If you are not sure, you're not really 100% sure, it doesn't hurt if you want to see an oncologist for an opinion or for a consultation. I don't think any oncologist would mind giving you doing a consultation and seeing you and recommend to either continue to follow with them or follow with the dermatologist.
Okay, good question. There's one here from Jackie that came through a couple minutes ago, and it was related to if you have melanoma on the cheek, which nodes would be biopsied if it's located in one of your cheeks?
Okay, so any melanoma pretty much on the body or on the face or the head and neck area, the way the surgery is done, which is the kind of the standard surgery that is being done, is to take a larger area of the skin surrounding that melanoma. And what usually takes place during that surgery is something called Sentinel lymph node biopsy, if you've heard the term. And that's when the surgeon injects a pretty much dye in that area, and that has a specific color, and that color goes to the follow the lymphatic drainage to the first lymph node, and that's how the surgeon knows which node to remove. And so the drainage could be different and could be sometimes confusing, but you know, an experienced surgeon is always or most of the time able to find that lymphatic drainage and remove the appropriate lymph nodes.
Okay, great question, Jackie. Thanks for joining our chat and for that great question. And we have one here from Andy. It's nice to hear from you, Andy. Can melanoma be genetic?
So that's a little complicated question. Mm-hmm. So it can. So there are genes that are reported to be associated with specifically associated with melanoma. And genetic testing sometimes can be done for patients who come from families that pretty much everybody in the family has melanoma. So that's the genetic part of melanoma where we do genetic testing. However, that's the least common things. The more common thing is what we see as a family tendency to have melanomas, meaning if one member of the family has melanoma, there's a higher chance of other family member having melanoma without having any abnormality in the genes themselves.
Okay, interesting. Good question. So I know we've got a lot coming in. You know, we are about halfway through our chat, so keep that in mind. But the next question is, what is the average age of a melanoma patient? Are they a little older than your average patient, a little younger?
So that's also a good question because you know, melanoma tend to affect a lot of younger patients. So patients in their 20s especially female patient in their 20s, melanoma is number pretty much the second most common cancer there. However, if you remember, I said initially that the incidence or the number of new cases of melanoma has been increasing, and the most increase has been reported in older men. So you see the kind of variation. So although it's common in younger folks, it's still the most increase that we're seeing and watching or observing is happening in older men.
Interesting. I wouldn't have expected that, but great question. Here's a question from Alec, and we're getting back to treatment. So after treatment, regardless of which treatment you've undergone, what are the chances of the cancer growing or recurring later in life?
Good. So that really depends on your stage of melanoma. So the likelihood or the kind of, the percentage of, or the likelihood of the cancer coming back is different for every stage. Even for stage 3, for example, you would think it's the same for all stage 3, but stage 3 is even divided in 4 categories, A, B, C, and D. So based on the stage is how we determine the likelihood of the cancer coming back or not.
Okay, good question, Alec. Here's one related to that. Is surgery ever warranted in a stage 4 patient with multiple lesions before, during, or after immunotherapy?
Surgery is warranted. We always try with surgery to achieve one of 2 things, either a cure. So if someone has one spot in the lung, for example, or one spot in the liver, we can consider surgery. The other indication for surgery is palliation, which is improving a symptom. So if a melanoma mass in the stomach or in the bowels causing bleeding, we do that surgery to help with the bleeding and minimize the bleeding. So in patient with multiple areas of cancer, surgery is done less commonly, unless there's really a good indication or a specific indication to consider surgery. We would not consider it for patient with multiple areas of melanoma.
Okay, great question, Wayne. Thanks for bringing it up. We've got one here, and this could be interesting. What is the top misconception about melanoma specifically?
Oh, well, there are many, so let's see.
There usually are.
Yeah, there are many. So number one is a lot of people don't really realize that melanoma as a skin cancer can go to other organs. So that's kind of the first conversation we have with them. It's like, how can skin cancer go to the liver or the lungs? So that's really something that I think people don't have a good understanding of. That it can be aggressive and it can be even a deadly disease, skin cancer is. I think the other misconception is that it kind of like it doesn't matter if the melanoma is back, then it's a death sentence, which is not true. With the newer treatments that we have, we're able to change that significantly. So even if the melanoma returns after surgery, we still have a lot of options to do for the patients.
So is there a particular stage that melanoma may typically spread to other organs if it's going to?
So it's kind of logically, stage 2 has a more chance of spreading than stage 1. Stage 3 has a more chance of spreading to other organs than stage 2. But what I would say from practicing melanoma for the past 10 years or more, melanoma can also be very unpredictable. So melanoma is capable, as I said earlier, that melanoma tend to go to the lymph nodes, but it's capable of sometimes skipping the lymph node and going to an organ as the first sign of spread. So we try to make it logical, but sometimes it's very unpredictable.
Okay. All right, we've got a follow-up question from Jackie related to what she asked earlier. And you know, you've talked about immunotherapy, we've talked about surgery as treatment options. She's heard about a cream that's used to treat melanoma. Do you have an opinion regarding that?
So if I have to guess,
Maybe Aldera?
yes. Okay, so that was my guess. There are some reports that a cream like Aldera is also works kind of on the immune system, but it's more local. So a patient kind of applies it on the specific spots where the melanoma is. That's been done mostly in earlier stages of melanoma, so not when melanoma is in different organs. And it's also, there are not a lot of study or data to support the use of Aldera in that indication. So what I would say is it's probably a good idea if it's part of a research study or a part of an experimental type of study to do that treatment. Routinely, I don't tend to use it routinely.
Okay. All right, great question. So we are about 3 minutes for the end of our chat. We've got a couple questions left. I'm going to take those. We'll certainly see what we can answer here. We've got one from Ananya, and hers is, does the amount of melanin content in the body have any sort of relationship with the possibility of developing melanoma?
Not really. I don't think that we've been able to measure the melanin. And melanin is that dye that kind of when people have moles, this is melanin. That dark spot or black spot, that's the melanin. So we don't have a way to measure that melanin content in the body. All we know is patients who have more moles or nevi, they tend to have higher risk of having melanoma.
Okay, interesting. So here's another one from Wayne. You've had some great questions today, Wayne. What's the best tool for detecting melanoma before, during, or after immunotherapy? Is it CT scans, PET scans, and why?
So that's a big question. So it really depends on the specific situation. If someone is on immunotherapy, for example, we do serial scans to see if they're responding to the treatment, and so that's mostly in metastatic disease or stage 4. If someone is on immunotherapy or any therapy for prevention, to prevent the melanoma from coming back, a lot of times we do CT scans, and these are usually done depending on the patient's stage, anywhere between every 3 to 6 months on pretty much a routine basis or regular basis up to usually 5 years. These are all guidelines. Everybody does it differently, but that's what I tend to do.
Okay. All right. Going back to the Aldera cream for just a second, Jackie wanted to find out, would you advise using the cream in conjunction with surgery?
So I will have to know more about the case. I don't tend to use Aldera cream. Some surgeons, I think, like it, but I still need to see a little more data on Aldera in melanoma to be convinced to use it as a standard therapy.
Okay. All right. Last question here, and it actually comes from the Cancer Center. Why should somebody go to the Simmons Comprehensive Cancer Center first for treatment?
I think there are for 2 reasons. Number one is we do often have the opportunity to participate in trials. So we do have some kind of an experimental or some kind of newer trials that look at newer treatment that could have potential for patients who don't have a lot of treatment options or have progressed on standard treatment options. So that's the first reason. The second reason is we do things here in a multidisciplinary fashion. So we meet on a weekly basis, we discuss our patients, and we come up with a treatment plan for the patients, specifically for these patients, with the surgeons, with the radiation oncologists, and so on, with the pathologists, the dermatologists, and so on. And we tend to be specialized. So for example, I'm a medical oncologist, but I specialize in melanoma. That's all the patients I see. So I think these 2 reasons are definitely the reason why I would recommend people to come here.
Okay, I think that's perfect. I want to thank everybody for tuning in. as usual, this will be available here on our Facebook page. We'll also upload it to our YouTube channel later this afternoon. We'll share that link in the comments section. Mainly, though, I want to thank you, Dr. Homsi, for
Thank you very much for
coming and answering all these questions. It's been a great chat.
Great, thank you. Thanks.
All right, have a great day.